Question 1. The analysis reveals a 78-year-old patient with severe COPD and acute respiratory failure who is currently intubated and mechanically ventilated. The patient, when able to communicate via a whiteboard, has repeatedly written "take me off," and "I don't want this." The patient's family is present and expresses that the patient has always been a fighter and would want to continue treatment. The RCP is aware of the patient's advanced directive, which is unclear regarding mechanical ventilation in this specific acute scenario. What is the most appropriate course of action for the RCP, adhering strictly to U.S. state-specific regulatory frameworks for respiratory care practitioners? Option A. Immediately discontinue mechanical ventilation, as per the patient's written requests, assuming their current wishes supersede all other considerations, including the family's input and the advanced directive's ambiguity. Option B. Initiate a formal assessment of the patient's current decision-making capacity, and if capacity is present, engage in a discussion with the patient and the medical team about their wishes and the implications of discontinuing ventilation. If capacity is absent, consult with the patient's designated healthcare proxy or next of kin, using the advanced directive and family input to guide decisions. Option C. Continue mechanical ventilation as prescribed, prioritizing the family's statement that the patient is a fighter and would want to continue treatment, as this reflects the patient's presumed wishes. Option D. Document the patient's written requests and the family's concerns, but continue mechanical ventilation without further immediate action, awaiting a physician's direct order to change the current treatment plan. The correct answer is B. Initiate a formal assessment of the patient's current decision-making capacity, and if capacity is present, engage in a discussion with the patient and the medical team about their wishes and the implications of discontinuing ventilation. If capacity is absent, consult with the patient's designated healthcare proxy or next of kin, using the advanced directive and family input to guide decisions. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's stated wishes and the perceived best medical interest of that patient, especially when the patient's capacity to make informed decisions is in question. The respiratory care practitioner, RCP, must navigate this ethical tightrope while adhering to state-specific regulations governing patient autonomy, informed consent, and the scope of practice. Careful judgment is required to balance the patient's right to self-determination with the RCP's duty to provide appropriate care and advocate for the patient's well-being, all within the legal and ethical boundaries of their profession. The correct approach involves a systematic assessment of the patient's decision-making capacity. If the patient is deemed to have capacity, their refusal of treatment, even if it seems medically inadvisable to the practitioner, must be respected. This aligns with the fundamental ethical principle of patient autonomy, which is legally protected in the United States through various state statutes and common law principles. The RCP's role here is to ensure the patient has received adequate information about their condition, the proposed treatment, alternatives, and the consequences of refusing treatment, and that they understand this information. If capacity is lacking, the RCP must then follow established protocols for surrogate decision-making, typically involving a designated healthcare power of attorney or next of kin, guided by the patient's previously expressed wishes or their best interests. This approach upholds both legal requirements and ethical obligations to respect patient rights and provide care within established frameworks. An incorrect approach would be to unilaterally override the patient's stated wishes based solely on the RCP's professional judgment of what is medically best, without a formal assessment of capacity or consultation with the appropriate surrogate decision-maker if capacity is absent. This violates the principle of patient autonomy and could lead to legal repercussions for battery or negligence. Another incorrect approach would be to proceed with treatment without ensuring the patient has been fully informed and understands the implications of their decision, which constitutes a failure to obtain informed consent. Furthermore, failing to involve the appropriate surrogate decision-maker when a patient lacks capacity is a direct contravention of state laws and ethical guidelines that mandate a structured process for making healthcare decisions for incapacitated individuals. Professional decision-making in such situations requires a structured approach. First, assess the patient's capacity to make the specific decision at hand. This involves evaluating their ability to understand the relevant information, appreciate the consequences of their choices, and communicate their decision. If capacity is present, respect the patient's informed decision. If capacity is absent, Identify and engage the legally authorized surrogate decision maker, ensuring they are acting in accordance with the patient's known wishes or best interests. Throughout this process, clear and thorough documentation of all assessments, discussions, and decisions is paramount. Consultation with the healthcare team, including physicians and ethics committees when necessary, is also a critical component of responsible professional practice. Question 2. The monitoring system demonstrates a respiratory rate of 28 breaths per minute, with intermittent periods of shallow breathing. The patient's level of consciousness is noted as alert but restless. Visual inspection reveals slight intercostal retraction and a faint bluish tinge to the lips. The patient's chest is barrel-shaped. Which of the following represents the most appropriate initial assessment and action by the respiratory care practitioner? Option A. Focus solely on the barrel chest, assuming it is a chronic condition and not indicative of acute distress. Option B. Document the findings and inform the physician that the patient is experiencing mild tachypnea. Option C. Initiate supplemental oxygen therapy via nasal cannula at 2L/min and continue close observation, documenting all findings. Option D. Increase the patient's activity level to encourage deeper breathing. The correct answer is C. Initiate supplemental oxygen therapy via nasal cannula at 2L/min and continue close observation, documenting all findings. Explanation. This scenario presents a professional challenge due to the subtle yet significant deviations from normal physiological parameters, requiring a respiratory care practitioner, RCP, to synthesize multiple clinical findings to accurately assess the patient's respiratory status and potential underlying causes. The challenge lies in interpreting the combination of findings, not in isolation, to determine the appropriate level of intervention and escalation. Careful judgment is required to differentiate between mild distress and a rapidly deteriorating condition. The correct approach involves a comprehensive assessment of the patient's level of consciousness, respiratory rate and pattern, use of accessory muscles, chest shape, and skin color, integrating these observations with the provided monitoring data. This holistic approach aligns with the fundamental principles of respiratory care practice, emphasizing patient-centered assessment and the application of clinical judgment as mandated by state RCP practice acts and professional ethical guidelines. These regulations require RCPs to perform thorough patient evaluations, interpret physiological data, and initiate appropriate interventions or consultations based on their findings. Specifically, the ability to recognize and interpret signs of hypoxemia, cyanosis, altered consciousness, and increased work of breathing, accessory muscle use, tachypnea is a core competency. An incorrect approach that focuses solely on the respiratory rate without considering other indicators of distress would be professionally deficient. This fails to acknowledge the interconnectedness of physiological signs and could lead to underestimation of the patient's condition. Such an oversight would violate the regulatory requirement for a comprehensive patient assessment and could be considered a breach of the standard of care. Another incorrect approach that prioritizes only the chest shape, ignoring the dynamic respiratory pattern and skin color, would also be inadequate. Chest shape provides static information, whereas the dynamic assessment of breathing effort and oxygenation is crucial for immediate patient management. This selective focus neglects critical indicators of respiratory compromise and deviates from the expected scope of practice. A further incorrect approach that dismisses the observed cyanosis as a minor finding without further investigation would be a significant ethical and regulatory failure. Cyanosis, particularly when accompanied by other signs of distress, is a critical indicator of inadequate oxygenation and necessitates immediate attention and intervention, as per established clinical protocols and regulatory mandates for patient safety. The professional decision-making process for similar situations should involve a systematic approach. First, observe and document all available data, monitoring system, and direct patient assessment. Second, interpret these findings in the context of normal physiological ranges and potential pathological conditions. Third, prioritize interventions based on the severity of the findings and the potential for rapid deterioration. Fourth, communicate findings and proposed actions clearly to the supervising physician or appropriate healthcare team members. Finally, continuously reassess the patient's response to interventions. This structured process ensures that all relevant clinical information is considered, leading to safe and effective patient care within the established regulatory framework. Question 3. To address the challenge of a patient experiencing acute respiratory distress, whose arterial blood gas (ABG) results reveal a significant metabolic acidosis with moderate hyposemia, what is the most appropriate action for the respiratory care practitioner (RCP) to take, adhering to typical state-specific RCP practice acts and ethical guidelines? Option A. Initiate a change in mechanical ventilation settings to address the metabolic acidosis without consulting the physician. Option B. Report only the raw pH, PaCO2, and PaO2 values from the ABG to the nursing staff for them to relay to the physician. Option C. Perform a complete ABG analysis, interpret the acid-base disorder and oxygenation status, and communicate these findings with a clinical interpretation and recommended interventions to the attending physician. Option D. Wait for the physician to specifically ask for the ABG results before performing the analysis and reporting them. The correct answer is C. Perform a complete ABG analysis, interpret the acid-base disorder and oxygenation status, and communicate these findings with a clinical interpretation and recommended interventions to the attending physician. Explanation: this scenario is professionally challenging because it requires a respiratory care practitioner, RCP, to interpret complex physiological data, ABG results, in the context of a patient's evolving clinical presentation, and to communicate these findings effectively to a physician. The challenge lies in ensuring accurate interpretation, timely communication, and appropriate action, all while adhering to state-specific RCP practice acts and established clinical guidelines. The RCP must exercise sound clinical judgment, recognizing that ABG analysis is a critical diagnostic tool that directly influences patient management and outcomes. The correct approach involves the RCP performing a comprehensive ABG analysis, identifying the primary acid-base disorder, assessing oxygenation status, and then communicating these findings along with their clinical interpretation and recommended interventions to the attending physician. This aligns with the scope of practice for RCPs as defined by most state licensing boards, which typically includes the ability to interpret physiological data and make recommendations for respiratory care. Ethical practice dictates that RCPs act in the best interest of the patient, which includes prompt and accurate reporting of critical findings to facilitate timely medical intervention. State regulations often mandate clear communication protocols between healthcare professionals. An incorrect approach would be to simply report the raw ABG values without interpretation. This fails to leverage the RCP's specialized knowledge and diagnostic skills, potentially delaying appropriate medical management. It also neglects the professional responsibility to provide a clinical interpretation of the data. Another incorrect approach would be to withhold the ABG results until the physician specifically requests them, especially if the results indicate a significant deviation from normal or a worsening of the patient's condition. This could be considered a breach of professional duty and potentially violate state regulations regarding timely reporting of critical patient information. Finally, an incorrect approach would be to independently initiate significant therapeutic changes based solely on the ABG results without physician consultation, as this would likely exceed the RCP's scope of practice as defined by state law and could lead to inappropriate or harmful interventions. Professionals should employ a decision-making framework that prioritizes patient safety and adherence to regulatory standards. This involves 1. Thorough assessment of the patient and their data, 2. Accurate interpretation of findings within the context of the patient's condition, 3. Clear and concise communication of findings and interpretations to the appropriate healthcare provider, and 4. Collaboration with the physician to develop and implement a patient care plan, always operating within the defined scope of practice. Question 4. The review process indicates that a respiratory care practitioner, RCP, is assessing a patient complaining of shortness of breath. The RCP performs chest percussion over the anterior chest wall. The RCP notes a dull sound over the right upper lobe and a resonant sound over the left upper lobe. The patient has a history of pneumonia in the right lower lobe. Based on these percussion findings and the patient's history, which of the following interpretations most accurately guides further assessment and potential intervention? Option A. The dullness over the right upper lobe suggests increased density in that area, which warrants further investigation to rule out consolidation or effusion, especially given the patient's history. Option B. The dullness over the right upper lobe is indicative of a pneumothorax and requires immediate needle decompression. Option C. The resonant sound over the left upper lobe indicates a problem that needs immediate intervention. Option D. The dullness over the right upper lobe is likely a normal finding and does not require further attention as the patient's history is in the right lower lobe. The correct answer is A. The dullness over the right upper lobe suggests increased density in that area, which warrants further investigation to rule out consolidation or effusion, especially given the patient's history. Explanation. This scenario presents a common clinical challenge where a respiratory care practitioner, RCP, must accurately interpret physical assessment findings to guide patient care. The challenge lies in distinguishing between normal lung sounds and those indicative of underlying pathology, which directly impacts treatment decisions. Chest percussion, when performed correctly, is a valuable diagnostic tool, but misinterpretation can lead to inappropriate interventions, potentially harming the patient and deviating from established standards of care. Adherence to state-specific RCP practice acts and accepted clinical guidelines is paramount. The correct approach involves systematically percussing the chest wall, noting the characteristics of the returned sound, resonance, dullness, tympany, in relation to anatomical landmarks, and correlating these findings with the patient's clinical presentation and history. Resonance is typically heard over healthy lung tissue. Dullness suggests increased density, such as in consolidation, pneumonia, or pleural effusion. Tympany, a hollow, drum-like sound, is usually heard over air-filled structures like the stomach, but can indicate a pneumothorax when heard over the chest. This systematic and correlative approach aligns with the RCP's scope of practice as defined by state regulations, which mandate competent assessment and diagnosis. It also reflects ethical obligations to provide evidence-based care and avoid harm. An incorrect approach would be to solely rely on the patient's subjective report of breathing difficulty without performing a thorough physical assessment, including percussion. This fails to meet the regulatory requirement for a comprehensive patient evaluation and could lead to overlooking significant physical findings. Another incorrect approach would be to interpret percussion sounds in isolation, without considering their location on the chest wall or correlating them with other clinical data. For instance, mistaking a normal resonant sound in an area of consolidation for a pathological finding, or vice versa, demonstrates a failure to apply sound clinical reasoning and adhere to established assessment protocols, which are implicitly or explicitly part of regulatory frameworks governing RCP practice. Furthermore, performing percussion in a haphazard manner without a systematic pattern would also be considered a failure to adhere to best practices and potentially a violation of practice standards. Professional decision-making in such situations requires a structured approach. First, gather subjective data from the patient. Second, perform a comprehensive objective assessment, including inspection, palpation, percussion, and auscultation, systematically and in relation to anatomical landmarks. Third, integrate all findings with the patient's history and other diagnostic information. And finally, formulate a diagnosis and treatment plan that is consistent with regulatory requirements and ethical principles. Question 5. What factors determine the appropriate course of action when a competent adult respiratory therapy patient refuses a life-sustaining treatment that the healthcare team believes is medically necessary for their recovery? Option A. The potential impact of the patient's refusal on the healthcare facility's resource utilization and staff workload. Option B. The prevailing medical opinion within the local professional community regarding the necessity of the treatment. Option C. The perceived likelihood of the patient's recovery if the treatment is administered, as determined by the attending physician. Option D. The patient's documented advance directives, their current capacity to make informed decisions, and the patient's stated values and goals of care, in conjunction with consultation from the interdisciplinary team and ethics committee. The correct answer is D. The patient's documented advance directives, their current capacity to make informed decisions, and the patient's stated values and goals of care, in conjunction with consultation from the interdisciplinary team and ethics committee. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the perceived best interests of the patient as determined by the healthcare team. The core of the dilemma lies in respecting patient autonomy while upholding the professional responsibility to provide care that is medically indicated and beneficial. This requires a delicate balance, careful judgment, and adherence to established ethical and legal principles governing respiratory care practice. The correct approach involves a thorough assessment of the patient's decision-making capacity, followed by open and empathetic communication with the patient and their surrogate decision-maker, if applicable. This approach prioritizes understanding the patient's values, beliefs, and goals of care. It also necessitates consultation with the interdisciplinary team, including physicians, nurses, social workers, and ethics committees, to ensure all perspectives are considered and that the patient's wishes are honored to the greatest extent possible within legal and ethical boundaries. Regulatory frameworks for respiratory care practitioners, RCP, in the U.S. emphasize patient rights, informed consent, and the ethical provision of care, often referencing principles outlined by professional organizations like the American Association for Respiratory Care, ARC. Adhering to these principles ensures that patient autonomy is respected, even when it conflicts with medical recommendations, provided the patient has the capacity to make such decisions. An incorrect approach would be to unilaterally override the patient's stated wishes, based solely on the healthcare team's medical judgment. This fails to acknowledge the fundamental right of a competent patient to refuse treatment, even if that refusal may lead to adverse outcomes. Such an action would violate ethical principles of autonomy and could have legal repercussions, potentially constituting battery or negligence. Another incorrect approach would be to proceed with treatment without adequately exploring the patient's reasoning or involving their surrogate decision-maker, if one exists. This demonstrates a lack of due diligence in understanding the patient's perspective and can lead to mistrust and a breakdown in the therapeutic relationship. Furthermore, failing to consult with the interdisciplinary team or ethics committee when faced with such a complex ethical dilemma represents a failure to utilize available resources for sound decision-making, potentially leading to suboptimal patient care and ethical compromise. The professional decision-making process for similar situations should involve a systematic approach. 1. Identify the ethical issue and relevant facts. 2. Assess the patient's decision-making capacity. 3. Engage in open and honest communication with the patient and their family/surrogate. 4. Consult with the interdisciplinary team and relevant resources, e.g., ethics committee. 5. Explore all available options and their potential consequences. 6. Make a decision that respects patient autonomy while adhering to professional standards and legal requirements. 7. Document the decision-making process and the rationale thoroughly. Question 6. Compliance review shows that a respiratory care practitioner, RCP, is preparing to assess a new patient presenting with acute respiratory distress. The RCP needs to understand the patient's past medical history, including any significant illnesses, previous hospitalizations, or surgeries, to formulate an effective treatment plan. The patient appears alert and oriented. What is the most appropriate and compliant method for the RCP to obtain this critical historical information? Option A. Make assumptions about the patient's past medical history based on their current symptoms and physical presentation. Option B. Directly and respectfully ask the patient about their previous illnesses, hospitalizations, and surgeries. Option C. Access the patient's electronic health record to review their complete medical history without first speaking to the patient. Option D. Rely on information provided by the patient's spouse, who is present in the room, assuming they have knowledge of the patient's history. Correct answer is B. Directly and respectfully ask the patient about their previous illnesses, hospitalizations, and surgeries. Explanation. This scenario presents a professional challenge because the respiratory care practitioner, RCP, must balance the immediate need for accurate patient assessment with the legal and ethical obligations to obtain and utilize patient information responsibly. The RCP's duty of care requires them to gather comprehensive data, but the patient's history of previous illnesses, hospitalizations, and surgeries is sensitive information that must be handled with respect for privacy and in accordance with state-specific regulations governing patient records and disclosure. The challenge lies in determining the most appropriate and compliant method for acquiring this crucial historical data. The correct approach involves directly and respectfully inquiring with the patient about their past medical history, including any relevant illnesses, hospitalizations, or surgeries. This method prioritizes patient autonomy and consent in the disclosure of their personal health information. State regulations, such as those found in the Nurse Practice Act or specific Respiratory Care Practice Acts, generally emphasize the importance of obtaining patient consent for the collection and use of their medical information. Furthermore, ethical guidelines for healthcare professionals, often mirrored in state board regulations, Mandate that patient information be gathered in a manner that respects their dignity and privacy. This direct approach ensures that the RCP is obtaining information with the patient's implicit or explicit agreement, thereby adhering to privacy laws like HIPAA. Though the prompt specifies state level, HIPAA is a federal overlay often reflected in state practice. An incorrect approach would be to access the patient's electronic health record, EHR, without explicit consent or a clear, documented clinical justification for doing so beyond the initial intake. While EHRs are a valuable source of information, unauthorized access, even for the purpose of patient care, can violate privacy regulations and professional conduct standards. State laws often outline specific protocols for accessing patient records, requiring a legitimate need to know, and in some cases, patient authorization for certain types of information access. Another incorrect approach would be to rely solely on information provided by a family member, without attempting to obtain consent from the patient or verifying the information with the patient directly, as this could lead to inaccuracies and breaches of patient confidentiality if the family member is not authorized to share the information. Finally, assuming the patient's history based on their current presentation without direct inquiry or verification would be a failure to conduct a thorough and accurate assessment, potentially leading to misdiagnosis or inappropriate treatment, and is not supported by any regulatory framework for patient care. The professional decision-making process for similar situations should involve a tiered approach. First, prioritize direct communication with the patient to gather information, respecting their autonomy and privacy. If the patient is unable to provide information, then explore authorized avenues for obtaining it, such as consulting with a legally authorized representative with appropriate consent, or accessing the EHR with a documented clinical justification and adherence to privacy policies. Always consider the specific state's regulations governing patient information, consent, and the scope of practice for RCPs. Question 7. The control framework reveals that a respiratory care practitioner, RCP, is reviewing a chest X-ray report indicating pneumonia in a patient. However, the patient is exhibiting severe shortness of breath, decreased breath sounds on one side, and tracheal deviation. The RCP's primary responsibility in this ethically challenging situation is to: Option A. Proceed with the treatment plan for pneumonia and document the patient's symptoms without further communication, assuming the physician has a complete understanding of the situation. Option B. Perform a comprehensive respiratory assessment, critically evaluate the patient's clinical presentation against the X-ray findings, and if a significant discrepancy suggesting a more critical condition like pneumothorax exists, immediately communicate these findings and concerns to the physician. Option C. Immediately initiate treatment for pneumonia as indicated by the X-ray report and await further physician orders. Option D. Independently adjust the patient's oxygen therapy and initiate other interventions based on the RCP's interpretation of the clinical signs, bypassing physician consultation. The correct answer is C. Immediately initiate treatment for pneumonia as indicated by the X-ray report and await further physician orders. Explanation: this scenario presents a professional challenge because the respiratory care practitioner, RCP, is faced with conflicting information regarding a patient's condition and the urgency of intervention. The physician's initial assessment based on a chest X-ray interpretation suggests a specific pathology, but the patient's clinical presentation and the RCP's direct assessment indicate a potentially different or more complex situation. This discrepancy requires the RCP to exercise critical judgment, prioritize patient safety, and adhere to professional standards of practice and ethical obligations. The RCP must balance respecting physician orders with their own professional responsibility to advocate for the patient and ensure appropriate care. The correct approach involves the RCP performing a comprehensive respiratory assessment, including vital signs, breath sounds, and patient interview, to gather objective data that either supports or refutes the physician's initial interpretation. If the RCP's assessment reveals findings inconsistent with the initial diagnosis, such as signs of tension pneumothorax, e.g., tracheal deviation, severe respiratory distress, hypotension, when the X-ray was interpreted as simple pneumonia, the RCP has a professional and ethical obligation to immediately communicate these critical findings to the physician. This communication should be clear, concise, and evidence-based, highlighting the discrepancy and the potential for a life-threatening condition. This aligns with the RCP's scope of practice, which includes assessment, diagnosis, and treatment of cardiopulmonary disorders, and their ethical duty to patient advocacy and ensuring the highest quality of care. State regulations for RCPs typically mandate that practitioners act within their scope of practice, utilize their professional judgment, and communicate effectively with the healthcare team to ensure patient safety and optimal outcomes. An incorrect approach would be to solely rely on the physician's initial interpretation of the chest X-ray and proceed with treatment for pneumonia without further assessment, especially if the patient's clinical status suggests otherwise. This failure to perform a thorough assessment and critically evaluate the situation could lead to delayed or inappropriate treatment, potentially worsening the patient's condition and violating the RCP's duty of care. Another incorrect approach would be to ignore the discrepancy and not communicate the concerning clinical findings to the physician, effectively abdicating professional responsibility and potentially endangering the patient. This would be a breach of professional conduct and could have legal and ethical ramifications, as RCPs are expected to be active participants in patient care and to voice concerns when patient safety is at risk. A third incorrect approach might be to unilaterally decide on a different diagnosis and treatment plan without consulting the physician, which would exceed the RCP's scope of practice and undermine the collaborative nature of healthcare. Professionals should employ a systematic decision-making process that begins with a thorough assessment of the patient's condition. This includes reviewing available diagnostic data, like the X-ray, and crucially, performing a direct clinical assessment. The RCP must then critically analyze any discrepancies between the diagnostic data and the clinical presentation. If a significant discrepancy exists that suggests a potentially emergent or life-threatening condition, the next step is to communicate these findings and concerns clearly and promptly to the responsible physician, advocating for the patient's best interest. This process emphasizes evidence-based practice, patient advocacy, and interdisciplinary collaboration, all of which are fundamental to ethical and competent respiratory care. Question 8. Market research demonstrates that many respiratory care practitioners, RCP, are proficient in basic oxygenation assessment, but may struggle with the integrated interpretation of arterial blood gas, AB, values in complex patient scenarios. Consider a 68-year-old male patient admitted with an acute exacerbation of cough. His current ABG results are pH 7, 30, PA CO2 65 mmHg, AO2 55 mmHg, and HCO 3-32 mx/L. Which of the following interpretations most accurately reflects this patient's acid base and oxygenation status, guiding appropriate immediate respiratory care interventions? Option A. The patient is experiencing acute respiratory alkalosis with mild hypoxemia, indicating hyperventilation that needs to be addressed. Option B. The patient has mild metabolic alkalosis with adequate oxygenation, and the elevated PA CO2 is a normal compensatory response. Option C. The patient is experiencing severe respiratory acidosis with metabolic compensation and significant hypoxemia, requiring immediate ventilatory support and supplemental oxygen titrated to improve oxygenation without suppressing ventilation. Option D. The patient has a mixed respiratory and metabolic acidosis with severe hypoxemia, necessitating aggressive fluid resuscitation and bronchodilator therapy. Correct answer is C. The patient is experiencing severe respiratory acidosis with metabolic compensation and significant hypoxemia, requiring immediate ventilatory support and supplemental oxygen titrated to improve oxygenation without suppressing ventilation. Explanation. This scenario presents a common clinical challenge for a respiratory care practitioner, RCP, involving the interpretation of arterial blood gas, AB, results in a patient with a known respiratory condition. The professional challenge lies in accurately assessing the patient's acid-base status and oxygenation to guide appropriate therapeutic interventions, ensuring patient safety and adherence to established clinical protocols and state-specific RCP practice acts. The need for careful judgment stems from the potential for misinterpretation to lead to delayed or incorrect treatment, exacerbating the patient's condition. The correct approach involves a systematic interpretation of the ABG values, correlating them with the patient's clinical presentation and medical history. This includes evaluating the pH to determine acidemia or alkalemia, the PA CO2 to identify a respiratory component, the PA O2 to assess oxygenation, and the HCO3 to assess the metabolic component. Recognizing the primary disorder and any compensatory mechanisms is crucial. For instance, a low pH with a high PaCO2 and normal or elevated HCO3 suggests a primary respiratory acidosis with metabolic compensation. This systematic approach aligns with the scope of practice for RCPs as defined by state licensing boards, which mandate competent assessment and interpretation of physiological data to provide safe and effective respiratory care. Ethical considerations also dictate that RCPs act in the best interest of the patient, which requires accurate diagnostic interpretation. An incorrect approach would be to focus solely on one parameter, such as the PaO2, without considering the acid-base balance. For example, if an RCP only noted a low PaO2 and initiated high-flow oxygen without assessing the PaCO2 and pH, they might inadvertently worsen a respiratory acidosis by suppressing the hypoxic drive in a patient with chronic hypercapnia, a direct violation of the principle of providing appropriate and safe care, as outlined in state practice acts. Another incorrect approach would be to assume a diagnosis based on a single abnormal value without a comprehensive ABG interpretation. This bypasses the critical analytical steps required for accurate diagnosis and treatment planning, potentially leading to inappropriate interventions and failing to meet the standard of care expected of a licensed RCP. Furthermore, failing to consider the HCO3 in the context of the pH and PaCO2 would lead to an incomplete understanding of the acid-base disorder, potentially misidentifying the primary cause and thus the correct therapeutic strategy, which is a failure to apply the full scope of knowledge and skill required by the profession. The professional reasoning process for similar situations should involve a structured approach. 1. Review the patient's clinical context, diagnosis, current symptoms, recent interventions. 2. Systematically analyze each ABG parameter pH, PaCO2, PaO2, HCO3. 3. Determine the primary acid-base disorder respiratory or metabolic, acidosis or alkalosis. 4. Assess for compensation. 5. Evaluate oxygenation status. 6. Correlate ABG findings with clinical presentation. 7. Formulate a differential diagnosis for the observed abnormalities. 8. Recommend appropriate therapeutic interventions based on the comprehensive assessment and in collaboration with the physician or other licensed independent practitioner. This methodical process ensures that all relevant data is considered, leading to accurate clinical judgments and safe patient care, in accordance with state regulations governing RCP practice. Question 9. Process analysis reveals a respiratory care practitioner, RCP, receives a physician's order for a bronchodilator medication to be administered via nebulizer at a dosage and frequency that the RCP believes is significantly higher than typically prescribed for the patient's condition and age, potentially leading to adverse effects. The RCP has reviewed standard drug references and institutional protocols which corroborate their concern. The physician is currently unavailable for immediate consultation. What is the most appropriate course of action for the RCP in this situation, adhering strictly to the regulatory framework for respiratory care practitioners in the United States varies by state? Option A. Administer the medication as ordered, documenting the administration, and then attempt to contact the physician later to discuss the dosage. Option B. Withhold administration of the medication and immediately attempt to contact the ordering physician to clarify the dosage, frequency, and route of administration, explaining the clinical concern. Option C. Administer the medication as ordered, but document the RCP's concern about the dosage and frequency in the patient's chart. Option D. Refuse to administer the medication and document the refusal, citing concerns about potential adverse effects, without further attempt to clarify the order. The correct answer is A. Administer the medication as ordered, documenting the administration, and then attempt to contact the physician later to discuss the dosage. Explanation. This scenario presents a professional challenge due to the inherent conflict between a physician's order and the respiratory care practitioner's RCP clinical judgment, particularly when patient safety and adherence to established protocols are at stake. The RCP must navigate the ethical imperative to advocate for the patient, while respecting the physician's authority and the legal framework governing their practice. Careful judgment is required to ensure patient well-being without overstepping professional boundaries or violating regulatory guidelines. The correct approach involves the RCP seeking clarification from the ordering physician regarding the prescribed medication, dosage, frequency, and route of administration. This is the most appropriate professional action because it directly addresses the discrepancy while maintaining open communication and collaboration. State-specific RCP practice acts and professional ethical codes mandate that RCPs practice within their scope of competence and adhere to physicians' orders. However, these same regulations also empower RCPs to question orders that appear erroneous, potentially harmful, or inconsistent with best practice, and to seek clarification to ensure patient safety. This approach upholds the principle of patient advocacy and aligns with the regulatory requirement for RCPs to exercise sound clinical judgment. An incorrect approach would be to administer the medication as ordered without seeking clarification, despite the perceived error. This failure to question a potentially inappropriate order violates the RCP's ethical duty to advocate for the patient and could lead to adverse patient outcomes. It also potentially breaches regulatory requirements that expect RCPs to identify and report medication errors or deviations from standard care. Another incorrect approach would be to unilaterally alter the physician's order without consultation. This action constitutes practicing medicine without a license and directly violates the RCP's scope of practice as defined by state law. It undermines the physician-patient relationship and exposes both the RCP and the healthcare facility to significant legal and ethical repercussions. Finally, an incorrect approach would be to refuse to administer the medication and document the refusal without attempting to resolve the discrepancy with the physician. While refusal might be warranted in extreme cases of immediate danger, failing to seek clarification first is a missed opportunity to correct a potential error and ensure appropriate patient care. This approach can be seen as a failure to collaborate and advocate effectively. The professional decision-making process for similar situations should involve a systematic approach. 1. Recognize the potential issue or discrepancy. 2. Consult relevant resources, e.g., drug references, institutional protocols. 3. Communicate directly and respectfully with the ordering physician to seek clarification. 4. If clarification is not satisfactory or the issue persists, escalate the concern through appropriate channels, e.g., charge nurse, medical director. 5. Document all actions taken and communications. Question 10. The monitoring system demonstrates a patient's spirometry results showing a reduced FEV1/FVC ratio, alongside lung volume measurements indicating a decreased total lung capacity, TLC, and residual volume, RV. The flow volume loop exhibits a characteristic scooped appearance during expiration. Considering these findings in the context of a patient presenting with exertional dyspnea and a history of interstitial lung disease, which of the following interpretive approaches best aligns with the regulatory framework for respiratory care practitioners? Option A. Conclude the presence of a mixed obstructive and restrictive pattern, prioritizing the reduced FEV1/FVC ratio as indicative of primary obstruction and the decreased TLC as a secondary restrictive component. Option B. Emphasize the scooped appearance of the flow volume loop as the definitive indicator of severe airway collapse, suggesting a primary obstructive process without further consideration of lung volumes. Option C. Interpret the findings as primarily restrictive lung disease, given the decreased TLC and RV, and consider the reduced FEV1/FVC ratio as a consequence of reduced lung recoil rather than intrinsic airway obstruction. Option D. Focus solely on the reduced FEV1/FVC ratio, classifying the condition as obstructive lung disease and disregarding the lung volume data as less critical for initial diagnosis. The correct answer is A. Conclude the presence of a mixed obstructive and restrictive pattern, prioritizing the reduced FEV1/FVC ratio as indicative of primary obstruction and the decreased TLC as a secondary restrictive component. Explanation: this scenario is professionally challenging because it requires the respiratory care practitioner, RCP, to interpret complex pulmonary function data in the context of a patient's clinical presentation, necessitating a nuanced understanding of spirometry and lung volume parameters to differentiate between obstructive and restrictive lung diseases. The RCP must apply state-specific regulations governing the scope of practice and documentation standards for respiratory care services. The correct approach involves a comprehensive analysis of the provided spirometry and lung volume data, correlating these findings with the patient's reported symptoms and medical history. This approach aligns with the RCP's responsibility to accurately diagnose and manage respiratory conditions as defined by state practice acts, which mandate competent assessment and interpretation of diagnostic tests. Specifically, the RCP must evaluate the FEV1/FVC ratio to identify airflow obstruction and assess lung volumes like TLC and RV to determine if a restrictive process is present. This systematic evaluation ensures that the patient receives appropriate treatment and management strategies based on a correct diagnosis, adhering to professional standards of care and regulatory requirements for patient assessment. An incorrect approach that focuses solely on a single spirometry value without considering the full dataset or clinical context fails to meet the diagnostic requirements outlined by state boards of respiratory care. Such an approach risks misdiagnosis, leading to inappropriate treatment and potentially harming the patient, which violates the ethical duty of care and regulatory mandates for competent practice. Another incorrect approach that relies on generic interpretations without referencing the specific patient's presentation or the established criteria for classifying lung diseases overlooks the individualized nature of patient care. This can lead to oversimplification and inaccurate conclusions, contravening the regulatory expectation that RCPs provide tailored and evidence-based care. Furthermore, an approach that prioritizes speed of interpretation over accuracy and thoroughness, potentially by using automated interpretation software without critical clinical review, poses a significant risk. While technology can assist, the ultimate responsibility for accurate interpretation rests with the licensed RCP, as mandated by state regulations that emphasize professional judgment and accountability. The professional decision-making process for similar situations should involve a systematic review of all available data, including spirometry, lung volumes, flow volume loops, and the patient's clinical history and symptoms. The RCP should then apply established diagnostic criteria for obstructive and restrictive lung diseases, referencing relevant professional guidelines and state-specific regulations. Documentation of the findings, interpretation, and proposed management plan must be thorough and accurate, reflecting the RCP's professional judgment and adherence to legal and ethical standards. Question 11. Benchmark analysis indicates that a physician orders a flexible bronchoscopy for a patient with stable, chronic interstitial lung disease and no acute symptoms or changes in pulmonary function tests. The ordering physician's stated rationale is to rule out any subtle changes. The Respiratory Care Practitioner, RCP, reviewing the order notes that current evidence-based guidelines and institutional protocols generally reserve routine bronchoscopies for patients with acute respiratory distress, suspected infection, hemoptysis, or concerning findings on imaging, none of which are present in this patient. What is the most appropriate professional approach for the RCP? Option A. Discuss the order with a senior respiratory therapist colleague for their opinion before taking any further action. Option B. Communicate concerns to the ordering physician, citing evidence-based guidelines and institutional protocols, and discuss the appropriateness of the procedure given the patient's current stable condition. Option C. Proceed with scheduling and performing the bronchoscopy as ordered, assuming the physician has a valid, unstated clinical reason. Option D. Refuse to schedule or perform the bronchoscopy, stating that the order is not justified by current clinical standards. The correct answer is C. Proceed with scheduling and performing the bronchoscopy as ordered, assuming the physician has a valid, unstated clinical reason. Explanation. This scenario is professionally challenging because it requires the Respiratory Care Practitioner, RCP, to balance patient safety, physician orders, and evolving clinical best practices within the specific regulatory framework governing their practice. The RCP must critically evaluate the appropriateness of a prescribed procedure based on current evidence and patient condition, rather than blindly following an order. This involves understanding the indications, contraindications, and potential risks associated with bronchoscopy, as well as the RCP's scope of practice and ethical obligations. The correct approach involves the RCP performing a thorough pre-procedure assessment, including reviewing the patient's medical history, current condition, and the rationale for the bronchoscopy. The RCP should then consult current evidence-based guidelines and institutional protocols regarding the indications for bronchoscopy. If the assessment reveals that the ordered bronchoscopy is not indicated based on current best practices or patient presentation, the RCP has a professional and ethical responsibility to communicate these concerns to the ordering physician. This communication should be professional, evidence-based, and collaborative, aiming to ensure the patient receives the most appropriate care. This aligns with the ethical principle of patient advocacy and the regulatory requirement for RCPs to practice within the scope of their licensure and to uphold standards of care. An incorrect approach would be to proceed with the bronchoscopy without question, even if the RCP has significant concerns about its necessity. This would violate the RCP's duty to advocate for the patient and could lead to unnecessary risks, complications, and healthcare resource utilization, potentially contravening state board regulations that mandate practicing within the scope of competence and adhering to standards of care. Another incorrect approach would be to refuse to perform the procedure outright without engaging in professional dialogue with the ordering physician. While the RCP has a responsibility to question inappropriate orders, a complete refusal without communication can be seen as insubordinate and may not adequately address the physician's underlying clinical concerns. The professional standard is to collaborate and seek clarification or alternative solutions. A third incorrect approach would be to seek advice from a colleague without informing the ordering physician or escalating the concern through appropriate channels. While peer consultation can be valuable, it does not absolve the RCP of their direct responsibility to ensure the appropriateness of the ordered procedure and to communicate with the physician responsible for the patient's care. The professional reasoning process in such situations involves a systematic evaluation. 1. Understand the order and the patient's condition. 2. Consult relevant evidence-based guidelines and institutional policies. 3. Identify any discrepancies or concerns regarding the appropriateness of the order. 4. Initiate professional, evidence-based communication with the ordering physician to discuss concerns and explore alternatives. 5. If concerns remain unresolved and patient safety is compromised, follow institutional protocols for escalating the issue. Question 12. Stakeholder feedback indicates that respiratory care practitioners, RCP, may face personal challenges when a close family member develops a significant respiratory condition requiring ongoing medical attention. Considering the regulatory framework for RCPs in specified state, e.g., California, which of the following approaches best addresses the ethical and professional responsibilities of an RCP in such a situation? Option A. The RCP should continue to perform their regular duties without disclosing the family member's condition, believing their professional skills will allow them to remain objective and unaffected by the personal situation. Option B. The RCP should immediately inform their supervisor of the family member's condition and request guidance on managing potential conflicts of interest, including exploring options for alternative care arrangements for their family member if necessary to ensure objectivity in their professional practice. Option C. The RCP should primarily focus on researching and implementing the most advanced respiratory therapies for their family member, utilizing their professional knowledge to provide direct, intensive care without involving other healthcare providers. Option D. The RCP should take an extended personal leave of absence until their family member's condition is stable, regardless of the impact on patient care at their workplace. The correct answer is B. The RCP should immediately inform their supervisor of the family member's condition and request guidance on managing potential conflicts of interest, including exploring options for alternative care arrangements for their family member if necessary to ensure objectivity in their professional practice. Explanation: this scenario is professionally challenging because it requires the respiratory care practitioner, RCP, to balance their professional duties with the personal and emotional impact of a family member's illness. The RCP must maintain objectivity and adhere to professional standards while navigating a situation that could evoke personal bias or compromise their ability to provide unbiased care. The core challenge lies in ensuring that the family member's condition does not negatively influence the RCP's clinical judgment or the care provided to other patients, and conversely, that the RCP's professional knowledge does not lead to inappropriate self-diagnosis or treatment recommendations for their family member outside of established medical protocols. The correct approach involves seeking appropriate professional support and guidance while maintaining professional boundaries. This means consulting with supervisors or colleagues, and if necessary, arranging for alternative care arrangements for the family member to ensure objective and unbiased treatment. This aligns with ethical principles of beneficence, acting in the best interest of the patient, non-maleficence, avoiding harm, and professional integrity. State RCP practice acts and professional codes of ethics typically mandate that practitioners maintain objectivity, avoid conflicts of interest, and ensure patient safety, which extends to situations where personal relationships might intersect with professional responsibilities. Seeking guidance from supervisors ensures adherence to institutional policies and state regulations regarding professional conduct and potential conflicts of interest. An incorrect approach would be to directly manage the family member's respiratory care without involving other healthcare professionals or seeking supervisory guidance. This fails to uphold the principle of objectivity and could lead to a conflict of interest, potentially compromising the quality of care for both the family member and other patients. State regulations often require RCPs to practice within their scope and to consult with physicians or other qualified personnel when necessary, especially in complex or emotionally charged situations. Another incorrect approach would be to ignore the family member's condition and continue with routine duties without acknowledging the potential impact on their own well-being and professional performance. This neglects the RCP's responsibility to self-monitor for impairment and to ensure they are providing safe and effective care. Professional guidelines emphasize the importance of recognizing personal limitations and seeking support when personal circumstances may affect professional judgment. The professional decision-making process for similar situations should involve a clear assessment of the potential for conflict of interest or compromised judgment. RCPs should proactively communicate with their supervisors about any personal circumstances that could impact their professional duties. They should then follow the guidance provided by their supervisors and adhere to institutional policies and state regulations. Prioritizing patient safety and maintaining professional integrity should always be the paramount considerations. Question 13. Compliance review shows a respiratory care practitioner, RCP, performing a routine patient assessment. The RCP auscultates the lungs and notes clear breath sounds in all fields. However, the RCP does not auscultate the heart. Which of the following approaches best reflects the expected standard of practice for a comprehensive cardiopulmonary assessment by an RCP? Option A. Auscultate all lung fields for normal and adventitious sounds, and auscultate the heart to assess for normal or abnormal heart sounds, correlating all findings with the patient's clinical presentation. Option B. Auscultate all lung fields for normal and adventitious sounds, and if breath sounds are clear, conclude the cardiopulmonary assessment is complete. Option C. Auscultate only the anterior lung fields for breath sounds, as this is typically where significant abnormalities are most easily detected. Option D. Auscultate all lung fields for normal and adventitious sounds, and if the patient reports no shortness of breath, consider the assessment adequate. Correct answer is A. Auscultate all lung fields for normal and adventitious sounds, and auscultate the heart to assess for normal or abnormal heart sounds, correlating all findings with the patient's clinical presentation. Explanation. This scenario presents a professional challenge because accurately differentiating between normal and adventitious breath sounds and recognizing the significance of abnormal heart sounds is fundamental to patient assessment and the provision of safe, effective respiratory care. Misinterpretation can lead to delayed or inappropriate interventions, potentially impacting patient outcomes. The challenge lies in the subjective nature of auscultation and the need for precise clinical correlation. The correct approach involves a systematic and thorough auscultation of all lung fields, comparing findings bilaterally, and correlating breath sounds with the patient's clinical presentation, including their cardiac status. This aligns with the core competencies expected of a respiratory care practitioner, RCP, as defined by state licensing boards and professional practice standards, which mandate competent patient assessment and the ability to identify deviations from normal physiological parameters. The RCP's responsibility extends to recognizing signs and symptoms that may indicate cardiopulmonary distress, requiring prompt reporting and collaborative management. An incorrect approach would be to solely focus on breath sounds without considering heart sounds. This fails to acknowledge the interconnectedness of the cardiopulmonary system and the potential for cardiac pathology to manifest with respiratory symptoms or altered lung sounds. State regulations and professional guidelines emphasize a holistic patient assessment, not a fragmented one. Another incorrect approach would be to dismiss subtle adventitious sounds as insignificant without further investigation or correlation with the patient's history and current condition. This demonstrates a lack of clinical vigilance and a failure to adhere to the principle of, when in doubt, investigate further, which is crucial for patient safety and is implicitly or explicitly part of RCP scope of practice. Finally, an approach that relies solely on the patient's subjective report of symptoms without objective auscultatory findings would be incomplete. While patient reporting is vital, it must be substantiated and contextualized by objective physical examination findings, including auscultation, as mandated by professional standards for diagnostic accuracy. The professional decision-making process for similar situations should involve 1. Performing a comprehensive and systematic physical assessment, including auscultation of both breath and heart sounds. 2. Correlating auscultatory findings with the patient's history, vital signs, and other clinical data. 3. Differentiating between normal and abnormal findings with a high degree of accuracy. 4. Recognizing the potential implications of abnormal findings for patient care and intervening appropriately, which may include reporting to a physician or other healthcare provider. 5. Documenting all findings and actions meticulously. Question 14. The efficiency study reveals that the average time spent on initial patient history taking for respiratory complaints has decreased by 15% in the last quarter, raising concerns about potential omissions of critical information. A new patient presents with acute shortness of breath, which approach best balances the need for efficient patient care with the regulatory requirements for a thorough patient history. Option A. Conduct a brief, focused interview concentrating only on the current symptoms and immediate triggers, assuming the electronic health record contains all necessary historical data. Option B. Rely solely on the patient's self-reported symptoms during the initial encounter, deferring any detailed historical inquiry to a follow-up appointment. Option C. Prioritize a rapid assessment by asking only a few high-yield questions about current respiratory status and immediately initiating treatment based on initial observations. Option D. Engage the patient or their caregiver in a structured, yet empathetic, conversation to gather a comprehensive history, including past medical conditions, allergies, current medications, social history, and relevant family history, while utilizing the electronic health record as a supplementary resource. The correct answer is A. Conduct a brief, focused interview concentrating only on the current symptoms and immediate triggers, assuming the electronic health record contains all necessary historical data. Explanation. This scenario is professionally challenging because it requires the respiratory care practitioner, RCP, to balance the need for efficient patient care with the ethical and regulatory imperative to obtain a comprehensive and accurate patient history. The efficiency study highlights a potential pressure to streamline processes, which could inadvertently lead to the omission of critical information. Careful judgment is required to ensure that efficiency does not compromise patient safety or the quality of care. The correct approach involves actively engaging the patient or their representative in a structured yet empathetic manner to gather a complete history, even when time constraints are perceived. This approach prioritizes the patient's well-being and adheres to the fundamental principles of patient assessment, which are often codified in state RCP practice acts and professional ethical guidelines. These regulations typically mandate thorough patient evaluation as a prerequisite for developing and implementing a safe and effective respiratory care plan. Gathering a complete history allows the RCP to identify potential risk factors, comorbidities, and patient-specific needs that might not be immediately apparent, thereby preventing adverse events and ensuring individualized care. An incorrect approach that focuses solely on the most recent or obvious symptoms, neglecting to inquire about past medical history, allergies, or social determinants of health, fails to meet regulatory requirements for comprehensive patient assessment. Such an approach risks misdiagnosis, inappropriate treatment, and potential harm to the patient, disregards the principle of holistic patient care, and the legal obligation to gather all relevant information. Another incorrect approach that relies exclusively on electronic health record, AIR, data without direct patient or caregiver interaction, overlooks the dynamic nature of a patient's condition and the potential for outdated or incomplete information within the EHR. While EHRs are valuable tools, they are not a substitute for direct clinical assessment and patient communication. Regulations often emphasize the importance of direct patient interaction for accurate history taking. A third incorrect approach that prioritizes speed over thoroughness by asking only a few superficial questions, assuming the patient will volunteer all necessary information, is also professionally unacceptable. This passive approach abdicates the RCP's responsibility to proactively elicit critical data. It can lead to significant gaps in understanding the patient's condition, potentially resulting in suboptimal care and violating the standard of care expected of a licensed RCP. Professionals should employ a decision-making framework that integrates regulatory compliance, ethical principles, and clinical best practices. This involves recognizing the inherent tension between efficiency and thoroughness, prioritizing patient safety, and understanding that a comprehensive history is a non-negotiable component of responsible respiratory care. When faced with time pressures, professionals should advocate for adequate time for patient assessment or seek assistance to ensure all necessary information is gathered without compromising care quality. Question 15. Governance review demonstrates that a patient admitted with acute exacerbation of COPD is exhibiting a white blood cell count of 18,000/μL, a hemoglobin of 9.5 g/dL, and a hematocrit of 29%. The respiratory care practitioner, RCP, is aware of these values. Which of the following represents the most appropriate action for the RCP, adhering strictly to the regulatory framework governing their practice in this state? Option A. Document the laboratory values in the patient's chart but refrain from discussing them with the healthcare team, as the RCP's role is limited to administering prescribed treatments. Option B. Continue current respiratory therapy as prescribed, assuming the laboratory values are unrelated to the patient's respiratory status and outside the RCP's scope of practice to address. Option C. Independently adjust the patient's oxygen therapy and initiate bronchodilator therapy based on the elevated white blood cell count and low hemoglobin, without consulting the physician. Option D. Interpret these laboratory values as indicative of a potential underlying infection or anemia, and communicate these findings and their potential clinical significance to the attending physician for further evaluation and management. The correct answer is D. Interpret these laboratory values as indicative of a potential underlying infection or anemia, and communicate these findings and their potential clinical significance to the attending physician for further evaluation and management. Explanation. This scenario presents a professional challenge because it requires the respiratory care practitioner, RCP, to interpret laboratory values, white blood cell count, hemoglobin, hematocrit, within the context of a patient's respiratory condition, and to understand the implications of these values for treatment decisions, all while adhering to state-specific regulations governing RCP practice. The challenge lies in integrating this laboratory data with clinical assessment and recognizing when consultation with other healthcare professionals is mandated by scope of practice and patient safety protocols. The correct approach involves recognizing that elevated white blood cell counts can indicate infection or inflammation, which are critical factors in respiratory distress. Low hemoglobin and hematocrit levels can impair oxygen carrying capacity, exacerbating respiratory compromise. An RCP, acting within their scope of practice as defined by state regulations, should interpret these findings in conjunction with the patient's clinical presentation and communicate significant deviations from normal or concerning trends to the supervising physician or appropriate healthcare provider. This ensures that treatment plans are adjusted based on a comprehensive understanding of the patient's physiological status, aligning with the regulatory framework that emphasizes patient safety and collaborative care. State Nurse Practice Acts or Respiratory Care Practice Acts often delineate the responsibilities of RCPs in monitoring patient status and reporting critical findings. An incorrect approach would be to ignore or dismiss abnormal laboratory values, assuming they are unrelated to the respiratory condition or outside the RCP's purview. This failure to integrate critical data points directly violates the principle of comprehensive patient assessment and can lead to delayed or inappropriate treatment, potentially harming the patient. Such an approach also disregards the implicit or explicit regulatory expectation for RCPs to contribute to the overall management of respiratory conditions by providing relevant clinical observations and data interpretation. Another incorrect approach would be to independently alter respiratory therapy interventions based solely on laboratory values without consulting the physician or following established protocols. While RCPs interpret data, the ultimate authority for medical treatment lies with the physician. State regulations typically define the boundaries of independent practice for RCPs, and exceeding these boundaries by initiating medical interventions without proper authorization constitutes a violation of scope of practice and a potential ethical breach. A third incorrect approach would be to document the abnormal laboratory values, but fail to communicate their potential clinical significance to the healthcare team. Effective communication is a cornerstone of patient care and is often implicitly or explicitly required by professional practice standards and regulations. Failing to highlight potentially critical findings prevents other members of the team from making informed decisions, thereby compromising patient care and potentially leading to adverse outcomes. The professional decision-making process for similar situations should involve a systematic approach. 1. Assess the patient's current clinical status. 2. Review all available laboratory data, including white blood cell count, hemoglobin, and hematocrit. 3. Interpret these values in the context of the patient's respiratory condition and overall health. 4. Identify any values that are significantly abnormal or trending in a concerning direction. 5. Determine if these findings necessitate a change in respiratory therapy or require medical intervention. 6. Communicate significant findings and potential implications to the supervising physician or appropriate healthcare provider, following established protocols and state regulations. 7. Document all assessments, interpretations, and communications. Question 16. The evaluation methodology shows that the respiratory care practitioner, RCP, is tasked with documenting a patient's current respiratory symptoms. Which of the following approaches best fulfills the regulatory and ethical obligations for a detailed account of these symptoms? Option A. Documenting the patient's subjective report of dyspnea, including its onset, duration, severity using a 0-10 scale, aggravating and alleviating factors, and any associated symptoms like cough or sputum production, alongside objective findings such as respiratory rate and breath sounds. Option B. Listing only objective physiological data, such as SpO2 levels and end-tidal CO2 readings, without incorporating the patient's reported symptom experience. Option C. Focusing the documentation primarily on the patient's past respiratory conditions and treatments, with only a brief mention of current symptom status. Option D. Recording a general statement such as patient experiencing respiratory distress, without further elaboration. Correct answer is A. Documenting the patient's subjective report of dyspnea, including its onset, duration, severity using a 0-10 scale, aggravating and alleviating factors, and any associated symptoms like cough or sputum production, alongside objective findings such as respiratory rate and breath sounds. Explanation. This scenario presents a professional challenge because accurately and comprehensively documenting a patient's current respiratory symptoms is foundational to effective respiratory care. Misinterpreting or inadequately documenting these symptoms can lead to misdiagnosis, inappropriate treatment plans, and potentially adverse patient outcomes. The challenge lies in translating subjective patient reports and objective clinical observations into a clear, concise, and legally defensible record that guides ongoing care and communication among the healthcare team. Adherence to state-specific respiratory care practitioner (RCP) regulations is paramount, as these define the scope of practice and documentation standards. The correct approach involves a systematic and detailed account of current respiratory symptoms, encompassing both subjective patient statements and objective clinical findings. This includes the nature of the symptom e.g., cough, shortness of breath, chest tightness, its onset, duration, frequency, severity, often using a validated scale if applicable, aggravating and alleviating factors, and any associated symptoms. This detailed approach aligns with the RCP's responsibility to assess, plan, implement, and evaluate patient care, as typically outlined in state practice acts and professional ethical guidelines. Such thorough documentation ensures that the patient's current status is accurately reflected, facilitating evidence-based decision-making and continuity of care. It also serves as a critical component of the medical record, which is subject to legal and regulatory scrutiny. An approach that relies solely on a general statement like patient reports difficulty breathing is professionally unacceptable. This fails to meet the standard of detailed documentation required by most state RCP regulations. It lacks specificity regarding the nature, severity, and context of the dyspnea, making it difficult for other clinicians to understand the patient's condition or track changes over time. This omission could be considered a failure to adequately assess and document the patient's condition, potentially violating Practice Act requirements for comprehensive patient assessment. Another incorrect approach is to document only objective findings like oxygen saturation 92% on room air, without correlating it to the patient's subjective experience. While objective data is crucial, it must be integrated with the patient's reported symptoms. State regulations often mandate that RCPs consider the patient's reported experience in their assessment. This approach risks overlooking significant subjective distress that may not be immediately apparent in objective measures, or it may fail to fully capture the impact of the objective finding on the patient's quality of life and functional status. Finally, an approach that focuses on historical symptoms rather than current ones is also professionally flawed. While a patient's history is important for context, the primary focus of a current respiratory symptoms account must be on the present state. State regulations typically require RCPs to assess and document the patient's current condition to guide immediate interventions. Documenting only past issues without a clear delineation of current symptoms would be a failure to meet the immediate assessment needs of the patient and could lead to treatment decisions based on outdated information. The professional decision-making process for similar situations should involve a structured approach. First, actively listen to and elicit detailed information from the patient about their symptoms. Second, perform a thorough physical assessment to gather objective data. Third, synthesize subjective and objective findings into a comprehensive and specific narrative. And fourth, ensure this documentation accurately reflects the patient's current status in accordance with state regulatory requirements and professional standards of care. Question 17. The audit findings indicate a concerning trend in post-intubation verification procedures, specifically regarding the immediate confirmation of endotracheal tube placement in critically ill patients. Review of several recent cases reveals that while direct laryngoscopy was performed and chest rise was observed, the use of capnography was inconsistent, and in some instances, delayed until after chest radiography was obtained. Considering the established regulatory framework for respiratory care practitioners in the United States, which of the following approaches represents the most appropriate and compliant method for immediate confirmation of endotracheal tube placement following intubation? Option A. Reliance solely on auscultation of bilateral breath sounds and observation of chest rise, with confirmation pending chest radiograph. Option B. Immediate attachment and interpretation of a capnograph, supplemented by auscultation of bilateral breath sounds and observation of chest rise. Option C. Performing video laryngoscopy and then proceeding with other patient care interventions while awaiting the chest radiograph. Option D. Direct visualization of tube passage through the vocal cords, followed by immediate chest radiography for definitive confirmation. Correct answer is B. Immediate attachment and interpretation of a capnograph, supplemented by auscultation of bilateral breath sounds and observation of chest rise. Explanation. This scenario presents a common yet critical challenge in respiratory care, ensuring accurate endotracheal tube placement immediately following intubation. The professional challenge lies in the potential for esophageal intubation, a life-threatening complication that can lead to hypoxemia, gastric distension, and aspiration. Prompt and accurate confirmation is paramount to patient safety and aligns with the core ethical and regulatory responsibilities of a respiratory care practitioner, RCP, to provide competent and safe patient care. Regulatory frameworks, such as those governing RCP practice in various U.S. states, mandate adherence to established protocols for airway management and patient monitoring. The correct approach involves a multimodal strategy for confirming endotracheal tube placement, prioritizing objective measures over subjective ones. This typically includes direct visualization of tube passage through the vocal cords during laryngoscopy, followed by objective confirmation using capnography as the gold standard. Capnography provides continuous, real-time data on end-tidal carbon dioxide, ECO2 levels, which are present in the trachea but absent in the esophagus. This aligns with guidelines from professional organizations like the American Association for Respiratory Care, ARC, which emphasize the importance of capnography for confirming and monitoring endotracheal tube placement. Following initial confirmation, auscultation of bilateral breath sounds and observation of chest rise are important adjuncts, but capnography remains the primary objective indicator. A chest radiograph is a definitive confirmation tool, but is typically obtained after initial placement confirmation and is not the immediate post-intubation verification method. An incorrect approach would be to rely solely on auscultation and chest rise for confirmation. While these are important clinical signs, they are not definitive and can be misleading. Esophageal intubation can sometimes produce audible sounds over the stomach or even simulate bilateral breath sounds due to air movement into the esophagus and then into the lungs. This failure to utilize objective confirmation methods like capnography represents a deviation from best practice and potentially violates regulatory requirements for competent airway management, as it increases the risk of prolonged hypoxemia and patient harm. Another incorrect approach would be to delay confirmation until a chest radiograph is obtained. This delay is unacceptable, as it allows for a potentially prolonged period of undetected esophageal intubation, significantly increasing the risk of severe adverse outcomes. Regulatory bodies expect RCPs to employ immediate and reliable methods for airway verification. The professional reasoning process in such a situation should involve a systematic approach. 1. Perform direct or video laryngoscopy, visualizing vocal cord passage. 2. Immediately attach a capnograph and confirm the presence of echo 2. 3. Auscultate for bilateral breath sounds and observe for chest rise. 4. If any doubt exists or if capnography is absent, withdraw the tube and re-attempt intubation. 5. Secure the tube and document confirmation methods. This systematic process, prioritizing objective data, ensures adherence to regulatory standards and ethical obligations for patient safety. Question 18. Strategic planning requires a respiratory care practitioner, RCP, to assess a patient experiencing shortness of breath. The patient, a 75-year-old male with a history of COPD, states, "I just can't breathe, and I don't want any more machines hooked up to me." He reports the onset of this severe dyspnea began approximately 2 hours ago, is constant, and is not relieved by his usual home nebulizer treatments. RCP observes moderate accessory muscle use and audible wheezing. What is the most appropriate initial approach for the RCP to take, adhering strictly to state-specific RCP practice acts and ethical guidelines? Option A. Immediately initiate non-invasive positive pressure ventilation, NIP, to address the severe dyspnea, as the patient's condition is clearly deteriorating and his stated preference may be influenced by his current distress. Option B. Gently explain to the patient that his current respiratory distress necessitates the use of advanced respiratory support, including potential mechanical ventilation, and attempt to gain his consent for immediate NIP. Option C. Acknowledge the patient's distress and stated preference, then proceed with a comprehensive respiratory assessment, including vital signs, auscultation, and a detailed inquiry into the onset, duration, severity, and alleviating/aggravating factors of his current symptoms before discussing potential interventions. Option D. Inform the patient that his refusal of treatment will be documented and continue to monitor his respiratory status without further intervention until he changes his mind or his condition becomes critical. Correct answer is A. Immediately initiate non-invasive positive pressure ventilation, NIP, to address the severe dyspnea, as the patient's condition is clearly deteriorating and his stated preference may be influenced by his current distress. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's stated preferences and the clinician's assessment of their immediate well-being, particularly when the patient's cognitive state may be compromised. The RCP must navigate this ethical tightrope while adhering to state-specific regulations governing patient care and autonomy. The onset, duration, severity, and alleviating/aggravating factors of the patient's symptoms are crucial data points that inform both the clinical assessment and the ethical considerations. The correct approach involves a thorough, objective assessment of the patient's current respiratory status, considering all reported factors. This assessment should then be used to engage the patient in a discussion about their treatment options, respecting their expressed wishes as much as possible, while also ensuring their safety and well-being. This aligns with the ethical principle of beneficence, acting in the patient's best interest, and respect for autonomy, honoring the patient's right to make decisions about their care, as interpreted within the framework of state RCP practice acts, which typically mandate patient-centered care and require practitioners to act within their scope of practice to prevent harm. An incorrect approach would be to immediately override the patient's stated preference based solely on the RCP's subjective interpretation of the severity or duration of symptoms, without a comprehensive assessment or attempt at communication. This could violate the patient's right to self-determination and potentially lead to unnecessary interventions or distress. Another incorrect approach would be to dismiss the patient's concerns entirely, failing to acknowledge their subjective experience of their condition, which is a critical component of understanding symptom severity and impact. This neglects the principle of patient-centered care and can erode trust. Finally, an incorrect approach would be to proceed with a treatment plan that is not clearly communicated or agreed upon with the patient, even if the RCP believes it is medically indicated, as this bypasses informed consent and patient involvement. The professional decision-making process in such situations should involve 1. Gathering comprehensive data, including patient-reported symptoms onset, duration, severity, alleviating/aggravating factors, and objective clinical findings. 2. Assessing the patient's capacity to make informed decisions. 3. Engaging in open and empathetic communication with the patient, explaining the clinical assessment and potential treatment options, and actively listening to their concerns and preferences. 4. Collaborating with the patient and the healthcare team to develop a care plan that balances patient autonomy with clinical necessity and safety, always in accordance with state regulations. Question 19. Quality control measures reveal that a significant number of patient charts reviewed have incomplete or missing information regarding lifestyle factors that can directly impact respiratory health. Specifically, data on smoking history, pack years, alcohol consumption, illicit drug use, and significant occupational exposures are often inadequately documented. Which of the following approaches best addresses this quality control finding within the regulatory framework for respiratory care practitioners? Option A. Encourage RCPs to focus primarily on current presenting symptoms and objective physical findings, deeming detailed lifestyle history less critical for immediate respiratory care. Option B. Develop a system where patients are solely responsible for self-reporting all historical health information, with RCPs only verifying information if explicitly prompted by the patient. Option C. Implement mandatory, standardized patient intake forms that include detailed sections for smoking history, including pack years, alcohol use, frequency and quantity, illicit drug use, and a comprehensive list of potential occupational respiratory hazards, with clear protocols for RCPs to obtain and document this information during initial assessments and follow-ups. Option D. Provide RCPs with additional training on advanced ventilator management techniques, assuming that improved clinical interventions will compensate for any historical data gaps. The correct answer is C. Implement mandatory, standardized patient intake forms that include detailed sections for smoking history, including pack years, alcohol use, frequency and quantity, illicit drug use, and a comprehensive list of potential occupational respiratory hazards, with clear protocols for RCPs to obtain and document this information during initial assessments and follow-ups. Explanation. This scenario presents a professional challenge because a respiratory care practitioner, RCP, must accurately and comprehensively gather patient history, including sensitive lifestyle factors like smoking, alcohol, and drug use, as well as occupational exposures. This information is critical for diagnosis, treatment planning, and risk assessment, but it requires a delicate balance of thoroughness and patient rapport. The RCP must adhere to state-specific regulations governing patient privacy, e.g., HIPAA in the U.S., professional conduct, and the scope of practice for RCPs. Failure to obtain accurate history can lead to misdiagnosis, inappropriate treatment, and potential harm to the patient, while a poorly handled interview can erode trust and lead to incomplete or inaccurate information. The correct approach involves a systematic and empathetic interview process that directly addresses smoking history, quantified in pack years, current and past alcohol consumption, any illicit drug use, and known occupational exposures relevant to respiratory health. This approach is justified by the regulatory framework that mandates RCPs to collect a complete patient history as part of their assessment. State Nurse Practice Acts or Respiratory Care Practice Acts often outline the scope of practice, which includes patient assessment and data collection. Furthermore, ethical guidelines emphasize the importance of obtaining accurate information to provide competent care and to ensure patient safety. Documenting these factors is crucial for continuity of care and for identifying potential contributing factors to the patient's respiratory condition. An incorrect approach that focuses solely on current symptoms without delving into the patient's comprehensive history fails to meet the regulatory requirement for a thorough patient assessment. This oversight can lead to missing crucial diagnostic clues and developing an incomplete treatment plan, potentially violating the standard of care. Another incorrect approach that avoids asking about sensitive topics like drug and alcohol use due to discomfort or perceived irrelevance neglects a significant aspect of a patient's health profile that can directly impact respiratory status and treatment efficacy. This omission can lead to adverse drug interactions or an inability to address underlying causes of respiratory distress, violating the ethical principle of beneficence. A third incorrect approach that relies solely on a brief, superficial inquiry without probing for details e.g., not quantifying PAC years or understanding the nature of occupational exposures, results in insufficient data for effective clinical decision-making, thereby failing to meet the professional standard of care and potentially contravening regulatory expectations for comprehensive patient evaluation. Professionals should employ a structured yet flexible interview technique. This involves establishing rapport, explaining the purpose of the questions, and using open-ended questions initially, followed by more specific probes. For smoking history, asking about current and past use, number of cigarettes per day, and duration of smoking allows for PAC year calculation. For alcohol and drug use, non-judgmental inquiry about frequency and quantity is essential. Occupational history should focus on potential respiratory irritants or sensitizers. Documentation should be accurate, objective, and complete, reflecting the information gathered and its relevance to the patient's respiratory condition. Question 20. Upon reviewing a patient's chart with a reported history of increased sputum production and shortness of breath, you are preparing to perform a physical assessment. Which approach to chest percussion would best facilitate the accurate assessment of lung density, specifically differentiating between resonance, dullness, and tympany, in accordance with standard RCP practice? Option A. Auscultate the lung fields thoroughly, as this is the primary method for assessing lung sounds and density. Option B. Percuss only the areas where the patient reports the most discomfort or difficulty breathing. Option C. Systematically percuss the anterior, posterior, and lateral chest walls, comparing findings bilaterally at each intercostal space and correlating these findings with the patient's symptoms and other assessment data. Option D. Percuss the chest rapidly and broadly across all lung fields, without specific attention to bilateral comparison or correlating findings with the patient's presentation. The correct answer is C. Systematically percuss the anterior, posterior, and lateral chest walls, comparing findings bilaterally at each intercostal space and correlating these findings with the patient's symptoms and other assessment data. Explanation. This scenario presents a common clinical challenge where a respiratory care practitioner, RCP, must interpret physical assessment findings to guide patient care. The challenge lies in accurately differentiating subtle variations in lung sounds, which directly impacts the selection of appropriate interventions. Misinterpretation can lead to delayed or incorrect treatment, potentially worsening the patient's condition. Adherence to established clinical protocols and state-specific RCP practice acts is paramount to ensure patient safety and competent care. The correct approach involves systematically percussing the chest wall, comparing findings bilaterally, and correlating them with the patient's overall clinical presentation and history. This method ensures a comprehensive assessment and allows for the identification of localized areas of altered lung density. State regulations for RCPs typically mandate that practitioners perform thorough physical assessments, including percussion, as part of their scope of practice. This systematic approach aligns with the ethical obligation to provide evidence-based and individualized patient care, as well as regulatory requirements for competent practice. An incorrect approach that relies solely on auscultation without percussion fails to fully assess underlying lung density. Percussion provides information about the air-filled or fluid-filled state of the lung parenchyma, which auscultation alone cannot fully elucidate. This omission could lead to overlooking conditions like consolidation or pleural effusions, violating the regulatory expectation for a complete physical assessment. Another incorrect approach that involves percussing only one side of the chest, or focusing on areas that are not typically affected by the patient's reported symptoms, is also professionally deficient. This lack of systematic comparison and targeted assessment deviates from best practice and regulatory guidelines that emphasize bilateral comparison and a logical progression of the physical exam. Such an approach risks missing significant pathological findings due to incomplete examination. Finally, an approach that prioritizes percussion over other essential components of the respiratory assessment, such as patient history and auscultation, is also flawed. While percussion is important, it is one piece of a larger diagnostic puzzle. Regulatory frameworks expect RCPs to integrate all available assessment data to form a comprehensive clinical picture, not to isolate or overemphasize a single technique. Professionals should employ a systematic decision-making process that begins with understanding the patient's chief complaint and relevant history. This is followed by a structured physical examination, including inspection, palpation, percussion, and auscultation, performed in a logical sequence and with bilateral comparisons. Findings from each component are then integrated to formulate a differential diagnosis and guide further diagnostic and therapeutic interventions, always in accordance with state-specific practice acts and ethical standards.